Let us discuss this case. The architecture of the betrayal. Arthur, our patient, spent his life understanding the structure. As an architect, he knew exactly how much weight a beam could hold and how a foundation anchored house to the earth. But at 62, Arthur's own foundation began to silently crumble. It started innocently, a heavy lift at the construction site that felt heavier than it should have. Within weeks, the betrayal deepened. Getting out of his favorite leather armchair required a momentum he no longer possessed. Reaching for a blueprint on the top shelf, left shoulder burning. It was profound, symmetrical, proximal upper and lower extremity weakness. A quiet strike at the very core of his movement. Yet, strange anomalies preserved his dignity. His face remained as expressive as ever. His shoulder blades lay flat against his back without a hint of scapular winging, and his hands, the tools of his trade, could still sketch a perfect steady line. His distal strength was entirely untouched. Months prior to this, Arthur's primary physician had noticed a spike in his cholesterol and prescribed a routine statin. When the weakness first crept in, the doctor promptly stopped the medication, diagnosing it as standard toxin myopathy. But weeks passed, and the darkness didn't lift. The weakness only grew, unlike the common fleeting phantom of statin toxicity. Arthur's strength continued its subacute descent. That is when he came to our clinic. When Arthur sat across from us, he looked like a man trying to solve a riddle with missing pieces. We explained that sometimes a medication leaves behind a ghost. In a fraction of patients, a statin doesn't just cause temporary irritation, it ignites an autoimmune firestorm known as immune-mediated necrotizing myopathy. To map out the enemy, we began our diagnostic architecture. The diagnostic blueprint. The blood work. Arthur's serum creatinine kinase became sky high, a roaring metric of muscle fibers in deep distress. Electromyography. As the needle electrode listened to his muscles, the monitor sang a troubled song. It cracked with fibrillation potentials, hissed with positive sharp waves, and showed short crowded myopathic motor unit potentials. His muscles were crying out in a language of electrical chaos. Antibody panel. The definitive piece of the puzzle arrived from the lab. Arthur's blood was highly positive for anti-HMG-CR antibodies. You should note here that Arthur had been a young adult or a child. This antibody would have appeared without any statin exposure at all, often acting as a subacute chameleon that mimics LGMD. In our minds, we also breathe a quiet sigh of relief that he did not carry the other notorious markers of IMNM, that is, anti-SRP antibodies. We knew from the experience that anti-SRP is a much fierce adversary marked by rapid merciless disease course, severe weakness, and a devastating tendency towards early muscle fibrosis and fat replacement. Those patients often battle severe neck weakness, head drop, dysphagia, that is difficulty swallowing, and cardiac complications, requiring ultra aggressive immediate intervention to salvage normal function. To confirm the diagnosis beyond a shadow of doubt, we looked for a tiny piece of Arthur's muscle under microscope. Arthur's muscle biopsy told a haunting, beautiful story of its own. In typical inflammatory myopathies, the tissue is choked with cellular soldiers. But Arthur's slide revealed a phantom war, that is, necrotic muscle fibers laying bare and broken, accompanied by a striking minimal inflammatory cell infiltration. Yet the immune system fingerprints were undeniable. Lit up under the special stain, the membrane attack complex was seen parked like a molecular tracking device on non-necrotic muscle fibers. while MHC1 upregulation stood out vividly, a clear distress signal raised by muscle tissue itself. Because the author's condition was autoimmune, simply stopping the statin wasn't enough. His immune system needed to be re-educated. We initiated a rigorous course of immunomodulatory treatment to halt the antibody-mediated destruction. We also ordered comprehensive cancer screening. IMNM can occasionally present as an overlap syndrome with a connective tissue disease or emerge as a paraneoplastic syndrome, a shadow cast by an undiscovered malignancy elsewhere in the body. Though the literature notes the risk of associated cancer is statistically higher in non-statin exposed anti-HMG CR patients compared to anti-SRP cases, we left no stone unturned. Arthur's screening came back entirely clear. 6 months later, Arthur walked into our clinic with a cane. His shoulders were squared and his posture was upright. The immunomodulators had done their work, silencing the phantom war within his cells. He reached out to shake our hands, a grip that was firm, central, and completely restored. He was ready to go back to building things that lasted longer.